Hi, this is Dr. Coucher. I will be talking to you about anti-infectives for pharmacology in Chapter 26. So, antibacterial, antibiotic, antimicrobials, hearing the way this is stated, these ways stated throughout this whole lecture. Antimicrobial therapy or antibiotic therapy is the use of medications to treat infections. These can be caused by bacteria, viruses, or fungi. But for the purpose of this lecture, we're going to be solely focusing on the anti-infectives. Now, whether natural or synthetic, we must use selective toxicity to kill or otherwise control these microbes without destroying our host cells. And some of the methods of actions for the antibiotics, destroying the cell wall that is present in bacteria, but not in the mammals, inhibiting the conversion of an enzyme unique for a particular bacteria's survival, or impairing protein synthesis in the bacteria ribosomes, which are never identical to human cells. So antibiotics can do a couple of things here. They can be a bacteriostatic or they can be a bactericidal drug. If they are a bactericidal medication, that means that they are lethal directly to that microorganism. If they are a bacteriostatic medication, they slow the growth of the microorganism, but it actually is destroyed by the patient's immune system response to the phagocytic cells. The macrophages and neutrophils would be what help to eliminate that bacteria. When we're talking about bacteriostatic drugs, we're looking at tetracyclines and sulfonamides. When we're talking about the bactericidal drugs, we're looking at penicillins and cephalosporins. So, disease-producing organisms may be a gram-positive, gram-negative. They could be bacterial, viruses, or, like I said, the fungi. But we're going to be focusing actually on the bacterial. We know that with viruses that we can give an anti-infective medication to the patient, but it is not going to kill the virus. The virus is going to take an antiviral medication. So we're not going to discuss anything but the bacterial at this point. And the degree to which these are pathogenic depends on the microorganism and its virulence. To identify any causative agents, we'll do gram stains. Those are done to help us to identify that microorganism. We'll take whatever body fluid that is we suspect of infection. We'll put it on the microscope. We'll look at the organisms and see which ones we can identify directly. And we'll talk on the next slide how we can identify those, and it's based upon their shapes. Other times, fluid cultures are done by using the medium for growth. What we're looking for is the colonies to reproduce and be grown over several days. Culture may be more preferable in most cases, and I think that in the hospital that's what you're going to see for the most part, is that we're going to use cultures. We want to make sure that we get those cultures before we start any antibiotic treatment. There are multiple factors that determine which medication is selected for clinical use, though. So remember I talked about having it underneath the microscope and looking. So what we're looking at is if they're the bacilli, they're going to be elongated looking. The cocci, spherical. The spirilla are going to be helical. Now included in this lesson are the antibacterial antibiotics that we're going to look at would be the penicillins and cephalosporins. We're also going to look at macrolides, tetracyclines, aminoglycosides, and fluoroquinolones. And we'll also look at sulfonamides. So there's a few things that I want you to take away from this. This is going to help you to think about. Now, I always want you to think about the nursing process along the way when we're treating a patient. And some things that we're going to look at: host factors, cytobacteria, the age of the patient, pregnancy. Host factors is the immune system of the patient. For example, if they're an immunocompromised person, then they're going to need some stronger bactericidal antibiotics. My mother had an incident not long ago where she went into the hospital for one thing and was found, and she has liver failure. So her her spleen actually holds all of her white blood cell count, all of her white blood cells, all of her platelets, all of her red blood cells. So she is always anemic, and never is her white blood cell count above 3,000. So when she went up to 6,000, she actually for her, she was in a massive infected state. And she had also had a surgery last year to replace a heart valve. So they really were aggressive with her. When you have an immunocompromised person, it's not just about killing the bacteria, but we have to look at a host of other things, such as, for her example would be the heart valve replacement. They had to send her home on 6 weeks of antibiotics and a PICC line so that we could prevent that bacteria attaching to that foreign body up there in the heart. The site of the bacteria. Certain sites can be difficult for antimicrobials to reach. Cerebrospinal fluid is a hard place. Endocarditis for patients if they have purulent abscesses and foreign objects. Now, why would cerebrospinal fluid be difficult? And think about it. What is it about it? And I will be answering this, but I'm wanting y'all to think along the way. So cerebrospinal fluid is difficult because of the blood-brain barrier. So when we're treating somebody with meningitis, we have to be able to reach beyond that blood-brain barrier to hit that infection. Endocarditis, this occurs because microorganisms will vegetate on the thrombus developed from injured endocardium, and they are then covered and concealed by that new thrombus, so that makes it difficult to treat this. So the normal defense mechanisms and antibiotics don't kill that bacteria, so we have to be pretty aggressive. If they have purulent abscesses, those are difficult to treat due to their poor blood supply. Vascular grafts, that again, talking about my mom, host factor cytobacteria, that vascular graft is a difficult place because it's going to attach to that foreign substance in there. Pacemakers are another place for bacteria that are hard to treat. Joint prosthesis, those are also very difficult. So age of the patient, the very young and the very old. Infants are at increased risk of antibiotic toxicity. And do y'all remember why? What is it about the infant that makes them at risk for that? Because I believe that there was actually a discussion board on this as well. So it's the infant kidneys and the liver functions are undeveloped. So this is why they have a slow excretion of this the antibiotics. So we can easily these can easily be toxic to an infant. The older patients may develop toxicity because they have reduced drug metabolism. So everything starts to slow down the older that we get. Pregnancy. Some antibiotics have a teratogenic effect on the fetus. Gentamicin would cause hearing loss to the infant. In addition, with pregnancy and infants, tetracycline also causes discoloration of the infant's developing teeth and increases the mother's risk of toxicity in pregnancy. And antimicrobials are generally avoided in mothers who are breastfeeding due to the danger of the nursing infant. And what a lot of times it will do is if mom needs to have these antibiotics, say she's in the hospital for mastitis, but we've tried PO antibiotics that are safe and okay to pass through the breast milk, but now we have to move on up to a different one, and it becomes a danger for the infant when it crosses through the breast milk. So we'll have her to pump and dump her milk. Some nursing measures that you want to think about when taking care of the patient. Perform hand hygiene before and after each patient contact because we want to prevent any further spread. If you're taking care of a patient who is on contact precautions, then please, by all means, put on your gown and gloves. Do not go into that patient's room and take care of the patient, then walk out and go into another patient's room and just think it's okay to use the hand hygiene. You take everything off in that room and you do the scrub stat to your hands. And then when you walk out of the room, you use the hand gel again. Ensure you recognize any invasive procedures that increase the chance of infection. IVs, Foleys, heart caths all increase that patient's risk. Encourage measures to prevent infections, so make sure patients are up to date on their immunizations. These are things that you can ask your patient. Are you up to date on those immunizations? Do you know when you had your flu shot? Do you know when you had your last pneumonia shot? Especially when we're talking about the elderly patients there. Teach patients the importance of taking the full course of antibiotics prescribed to them. Why? Why is that so important? How many of you take your own antibiotics and you'll get day 5 in and you decide, I feel so much better now, I'm just going to stop? How many have those family members that are like that? I have several family members that are like that, and they run the risk of developing resistance and recurrence to those infections. Evaluate the effectiveness of treatment as well. So explain the mechanisms of actions of antibacterial drugs. There's inhibition of the bacterial cell wall synthesis, protein synthesis, and we talked a little bit about that on one of the previous slides, and synthesis of bacterial RNA and DNA. There's also the alteration of the membrane permeability, and then what we're looking at is it interfering with the metabolism within the cell itself. So, differentiate between the bacteria that are naturally resistant and those that have acquired resistance. Natural resistance occurs without previous exposure to the antibacterial drug. And acquired resistance is caused by prior exposure to antibacterial and misuse of antibiotics, so skipping doses or not taking the full antibiotic regimen. Nosocomial infections are those acquired while the patient is in the hospital. Many are due to drug-resistant bacteria. And then we have a cross-resistance that can occur between antibacterial drugs that have similar actions. Summarize the 3 general adverse effects associated with antibacterial drugs. We have allergy or hypersensitivity. With a mild allergic reaction, they're going to have rash, pruritus, or hives. With a severe allergy or anaphylactic shock, these patients could have bronchospasm, laryngeal edema, vascular collapse, and cardiac arrest. The treatment, we're going to give them an antihistamine, epinephrine, and a bronchodilator. We want to summarize the 3 general adverse effects associated with antibacterial drugs. If they have a superinfection, it's a secondary infection, so the normal flora is killed, and the sites would be the mouth, skin, respiratory tract, vagina, and intestines. It usually occurs when treated more than 1 week. Organ toxicity, the liver and the kidneys are involved in the drug metabolism and excretion. So an example, an aminoglycosides can be nephrotoxic as well as ototoxic. When we differentiate between narrow spectrum and broad spectrum antibiotics, with a narrow spectrum, primarily effective against one bacteria type. And those examples of antibiotics would be penicillin and erythromycin. Broad spectrum, effective against gram-positive and gram-negative. So some examples would be the tetracycline, cephalosporins. These are frequently used to treat infections when the offending microorganism has not been identified by CNS. So comparing the effects of the natural broad spectrum and penicillinase-resistant and extended spectrum penicillins. This is outcome 5. Penicillins are referred to as the beta-lactam antibiotics. Penicillin's beta-lactam ring structure interferes with the bacterial cell wall synthesis because it inhibits the bacterial enzyme that is necessary for cell division and cellular synthesis. Penicillins can be both bacteriostatic and they can be bactericidal depending on the drug and the dosage. Penicillin G is primarily bactericidal. Basic penicillins were introduced to kill Staphylococcus. They inhibit, like I said, the bacterial cell wall synthesis, and they're narrow spectrum. So those examples again: penicillin G, procaine penicillin, and penicillin V. They can treat moderately serious infections and lower respiratory infections as well. And interesting, these were the first antibiotics to be administered orally and by injection. So broad spectrum penicillins, they fight against gram-positive and gram-negative. Some examples of that would be Escherichia coli, Haemophilus influenza, Shigella dysentery, Proteus mirabilis, and Salmonella. There again, they can be bactericidal, so the treatment would be for lower respiratory tract infections, UTIs, some skin infections, and otitis media. Also known as aminopenicillins, examples would be the amoxicillin and ampicillin, and you might see that as amoxil or omnipin. So when we compare the effects of the natural broad spectrum penicillinase resistant and extended spectrum penicillins, when we're looking at the penicillinase resistant penicillins, those are used to treat the penicillinase producing S. aureus. So bone, joint, and skin infections would be the things that we would treat with it. It is also known as the anti-staphylococcal penicillins. So dicloxacillin, donipin, nafacillin, or it can be known as unipin, or oxacillin, which is prostaphyn. So table 26.3 in your text actually lists all of your antibiotics, your penicillins. It lists your basics, your broad spectrum, the penicillinase, and the extended spectrum penicillins, which is what we're looking at right now. One that you're going to see pretty often in the clinical setting at this point is Zosyn or piperacillin. That's an extended spectrum penicillin. Used to treat a lot of bone, joint, skin, soft tissue, respiratory tract, and urinary tract infections. And you know, it used to be when Zosyn first became pretty popular in the clinical setting that we would see it, and we would administer it over 30 minutes to an hour. And now they have Zosyn set up where it goes in IV piggyback, and it's slow over an extended period of time. And this is what you're going to see a lot of times when you have some extensive infections that are going on in some of the patients. If we contrast the effects of the first, second, third, and fourth generation cephalosporins, now let's talk about they have also a beta-lactam structure. They are semi-synthetic. They inhibit bacterial cell wall synthesis. They are bactericidal, and they will treat respiratory, urinary, skin, bone, joint, and genital infections. So remember me talking about some takeaways from this lecture would be looking at the age of the client. So when we're talking about giving antibiotics or any type of medication to our geriatric patients, we have to be concerned about the toxicity. We have to be concerned about their kidney function. So this being the cephalosporin also being a beta-lactam antibiotic, it is excreted in the kidneys, via the kidneys. So with older adults, assessment of renal function is really important. We need to look at their BUN. We need to look at serum creatinine that has to be monitored with these patients, because with the decrease in renal function, the antibiotic dose should be decreased as well, because we do not want to put them in a toxic state. So again, we're talking about cephalosporins and them being a beta-lactam antibiotic. And a first generation with them, Duracef, Ancef, K-Flex, we've all seen most of these out there in the clinical setting. These treat the gram-positive bacteria such as E. coli and Klebsiella. Second generation, Cephalocore, Cefotetin, Cefoxitin, let's see, I'm looking Cefzil. Yeah, these are going to treat your gram-positive and gram-negative Neisseria gonorrhea, Haemophilus influenza, Neisseria meningitis. All right, so our third generations, Omnicef, Suprax, Vantin, Fortaz, Rocephin, those are treating the gram-positive and gram-negative. Fourth generation, Maxipine, Cefepime, Those treat the gram-positive and gram-negative. So you're looking at streptococci, staphylococci. Okay, so when we're looking at our nursing process, what do we want to assess? We want to assess for any allergy to penicillins or cephalosporins. If a patient is hypersensitive to amoxicillin, should they not take any type of penicillin products? We want to look at laboratory results, especially liver enzymes. If they have an elevated alkaline phosphatase, if we need to look at urine output, if the amount is inadequate, less than 30 mL an hour, or greater than 600 mL a day, or less than 600 mL a day, the drug or drug dosage may need to be changed, because remember we talk about the elderly. In the geriatric population, we have to worry about their BUN and creatinine. We need to adjust their dosages based upon what that is showing. Nursing diagnoses, we're going to look at infection, risk for skin integrity, non-compliance with drug regimen. We have this a lot. What about, and here's my thing, we look at non-compliance, but is this because the patient is not wanting to take the medication, failing to remember to take it? What can we do to help them to remember to take it? Could they, if they have medications that they take daily, it might encourage them that if they have a pill box, to make sure that they put their medication in there. If it's twice a day, have one of those doubles for morning and night, so they got their morning meds and their night meds. Maybe they can set an alert on their phone. That's one thing that I encouraged my father to do with one of his medications. He just couldn't, he wanted to take it every night before he went to bed so that he didn't have to worry about the nauseating effects of it. And so it was just hard for him to remember to take it because it was outside of his norm. So you might want to encourage a patient to set an alarm on their phone so that they'll remember to take it at that particular time of day. What about planning? We want the patient's infection to be ultimately to be controlled and eliminated. And teaching. One of the things that we want to do, what I just did on interventions, is patient teaching with setting an alert on their phone so that they're compliant with taking their medication. Look at cultural considerations. Look at the elderly or the extremely young. We have to think about these intervening for these type of populations. Because patient teaching is definitely not going to be towards the infant. It's going to be towards mom and dad. Advise patients that are allergic to penicillins to wear a medical alert bracelet. It's important that we know that. Maybe they can or have something in their history somewhere so that we know not to give them a penicillin. Report any side effects or adverse reactions. Warn patients or the parents of children taking antibiotics that chewable tablets must be chewed or crushed before they start to swallow it. Let's see. Advise female patients of childbearing years to use an additional form of birth control. That's one thing that I think that we forget a lot, is if you are on a birth control that and you're prescribed an antibiotic, you need to encourage them to use other forms of birth control, because their antibiotics are going to make their birth control ineffective. And of course, when we're looking at evaluation, we're evaluating the effectiveness of the antibacterial that they've been given, if their infection has been resolved or not. What about any side effects, including superinfections that might have occurred? All right, so now we're going to look at macrolides, such as erythromycin. The action, it binds to the 5-OS ribosomal subunits and inhibits protein synthesis. It is a broad spectrum antibiotic, most gram-positive and some gram-negative. It is a bacteriostatic in a low to moderate dose, but it is bactericidal in a high dose. We can give this oral or we can give it IV. So uses: moderate to severe infections, respiratory, GI tract, skin and soft tissue, sexually transmitted infections. It will treat mycoplasma pneumonia, and it'll treat Legionnaire's disease as well. Side effects and adverse reactions, tinnitus or an ototoxicity with this medication. They can have some GI distress. They can also be at risk of superinfection and a hepatotoxicity. Some of these examples of the macrolides are the erythromycin, clarithromycin, and azithromycin, or Zithromax. So there are things that we need to be concerned about with the macrolides. Drug interactions. We need to look at levels of warfarin, theophylline, carbamazepine increase. Erythromycin levels increase with fluconazole, diflucan, or nazarol. So they have a risk of sudden cardiac death. Erythromycin levels may be reduced also by antacids. All right, so what do we want to look at about our nursing process with the macrolides? What about our assessment? We want to look at vital signs. We want to look at urine output. We want to report anything that's abnormal. Check our lab results, liver enzyme values. We need to determine the patient's liver function. We need to order liver enzyme tests periodically for the patients taking large doses of azithromycin for continuous periods. What about a history of the current drugs the patient has taken? These are all things that we want to look at. We want to look at nursing diagnoses. Of course, risk for infections, especially superinfection, is going to be in there. For the patients who are on antibiotics, there's a risk of noncompliance. We want to look at the tissue integrity as a nursing diagnosis also. With nursing interventions, check the culture and sensitivity before therapy. Again, monitor liver enzymes. Advise patient to take the full regimen. We don't want them to stop. We want to administer antacids 2 hours before or 2 hours after they take a macrolide. Give azithromycin 1 hour before or 2 hours after meals with a full glass of water. So let's look at glycopeptides and aminoglycosides. They work by inhibiting bacterial protein synthesis. They are a bactericidal. Their uses, serious infections of the bone, the skin, and the lower respiratory tract. An example would be vancomycin or telavancin. One thing with this medication is we need to be on alert for red neck or red man syndrome. It occurs when IV is given too rapidly. They get severe hypotension, red blotching of the face, neck, chest, extremities. It's a toxic reaction and not an allergic reaction. They also are at risk for ototoxicity with this medication, nephrotoxicity, blood dyscrasia, and Stevens-Johnson syndrome. Route is going to be either oral or IV. Nursing interventions, check CNS before therapy, monitor vancomycin levels, administer over 1 to 2 hours IV. We want to rotate the sites. We want to monitor the blood pressure, monitor the IV site, monitor the renal function test and hearing, and then monitor patients for superinfections. So now we're going to look at tetracyclines. And the action of tetracyclines inhibit the protein synthesis. These are usually broad spectrum. They fight gram-positive and gram-negative bacteria. Usually fights Helicobacter pylori, treats acne. That can be done with oral or topical use. They are can be bacterial resistant. It's going to be IV, IM, or an oral route that this medication is administered. Side effects and adverse reactions to tetracyclines, photosensitivity, discoloration of permanent teeth. Remember, we talked about that earlier on when I said there were some takeaways from this lecture. That is a risk with infants that their permanent teeth will be discolored, yellowed. stomatitis, GI distress, pseudomembranous colitis. They are at risk of blood dyscrasia, superinfections, CNS toxicity and hepatotoxicity, and nephrotoxicity in high doses. There's a lot of cicities in there. I almost got tongue-tied. Drug and food interactions can occur with tetracyclines. So milk products and antacids, oral contraceptives, digoxin absorption is increased, so it can lead to some toxicity. This is why it's important when we are starting a patient on a new medication that we get a full record of what medications that they are taking. We want to check CNS before we give the drug, administer 1 hour before or 2 hours after meals. We need to monitor kidney and liver function, store out of light and extreme heat, advise patient to use sunscreen. That's just about with any antibiotic though. Teach the patient to report a superinfection, warn patient to avoid milk, iron, and antacids, and tell patient to use effective oral hygiene when they are on this medication. All right, so we need to talk about detecting ototoxicity and nephrotoxicity associated with administration of aminoglycosides. Aminoglycosides inhibit bacterial protein synthesis, gram-negative E. coli, Proteus pseudomonas, and they're also a bactericidal antibiotic. Some examples of these drugs: Amicin, gentamicin, we all know gentamicin, Cantrex, neomycin, streptomycin, and tobramycin. These are all some of examples of aminoglycosides that we're going to see and that we're going to look at in your textbook. And I advise you to look at your tables in here. I already told y'all one table to look at. And I really expect y'all to look at those, because that's where, I'm going to take test questions based upon the medications and taking care of our patients and doing teaching and using the nursing process. The side effects to it are ototoxicity and nephrotoxicity. Nursing interventions, we're going to want to check the CNS, of course. That's going to be a given. Monitor renal function and hearing loss. Warn patient to use sunscreen. Monitor for superinfections. And then we have to monitor peak and trough levels with these medications. Now our next one is fluoroquinolones or quinolones. Their action interfere with the enzyme DNA gyrase. They fight gram-positive and gram-negative bacteria. These are a broad spectrum antibiotics, so they are bactericidal. Cipro is an example of one. It treats urinary tract infections, lower respiratory tract infections, skin, soft tissue, bone, and joint infection. Naroxen treats urinary tract infections. Levaquin, community-acquired pneumonia, chronic bronchitis, acute sinusitis, urinary tract infections, and uncomplicated skin infections. Avelox, once a day oral and parenteral dosing. It's used to treat the same infections other fluoroquinolones are effective against. Now, they also have, these medications have drug interactions. Antacids decrease their absorption rate. Levofloxacin increases effect of oral hypoglycemics, and it also theophylline and caffeine as well. Infuse IV over 60 to 90 minutes. Increase fluid intake to more than 2,000 mils per day. Tell patient to avoid caffeine, and then we also want to check for superinfections with these medications. So we're going to once again look at our nursing process for this medication. We want to do intake and output, record vital signs. We need to assess lab results. We want to look at their BUN and serum creatinine because we need to look at the patient's overall renal function. We need to look at their drug and their diet history. Remember, we have some interactions there. Antacids and iron preparations decrease the absorption of fluoroquinolones. So we need to make sure that we have a full history there. And let's see, when levofloxacin is taken with non-steroidal anti-inflammatory drugs, central nervous system reactions may occur, which include seizures. So we need a full history. What about nursing diagnoses? Again, risk for infections. Tissue integrity is going to be a risk for impaired tissue integrity. Non-compliance, especially when would you think about if there's some drug or food interactions? Like I would have some problem with my caffeine intake. And so I might be one of those patients that there's no way I'm going to do without my coffee and all the caffeine that I want. So I might be non-compliant when using this medication. So we need to look at non-compliance. We want to make sure the patient's infection for planning purposes is controlled and taken care of, ultimately eliminated. Interventions. We want to make sure that we do appropriate patient teaching. Drink to at least 6 to 8 glasses of water daily, and not just pour it in a cup. They need to be able to measure out 8 ounces. Some people think that they pour a little tiny amount in a cup and they've drinking a full cup of water, when in fact they probably only drink a couple of ounces, maybe 4 ounces of water. So a full glass of water is 8 ounces. So we need them to increase their fluid intake. And avoid caffeinated products, which again would be a problem with me. So I mean, I would be your non-compliant patient. I'll be the first to admit it would be hard for me to take one of these medications knowing I couldn't drink my coffee. Direct patients to avoid operating motor vehicles or hazardous machinery while taking the drug, because we need to make sure that they got good drug stability. What if they're taking NSAIDs? It can increase their risk of what did I say? Seizures, for one. So make sure that there is not any meloxicam that they're taking. Make sure that they don't take any Aleve on a daily basis. You know, it may be something that they don't have reported in their drug history. So anything that's over the counter that's an NSAID, we need to be able to obtain that information from them. So cultural considerations, we have to look at this because we have such a large growing Hispanic population. We need to be interested and make sure that the patient's personal matters are important to us as well. We need to be able to establish that trust with them. And that's sometimes hard to do, especially if in the past they haven't had a good result from other healthcare workers. Then they might be less inclined to trust us. All right, so now we're moving on to sulfonamides. Their action: inhibit bacterial synthesis of folic acid. They're bacteriostatic. They fight gram-negative bacteria. Their uses: otitis media, respiratory infections, UTI, prostatitis, gonorrhea, and it's also alternative therapy for patients that are allergic to penicillin. They're going to be given oral, IV, topical, or ophthalmic. Some adverse effects with it: GI distress, stomatitis, photosensitivity, crystalluria, renal failure, blood dyscrasias, and Stevens-Johnson syndrome. I'll tell you right now, I take this medication because I'm allergic to penicillin. And every time I take this medication, one thing that happens is I will get thrush. So make sure that you are with any patient that's on antibiotics, make sure that you are doing more than evaluating and asking if they're having anything going on genital wise. You need to look at their mouth. You need to see if they have any coating on their tongue, especially patients that are diabetics. They are more at risk of developing thrush. So that's a really big nursing assessment there to take from that. Interventions increase their fluid intake, monitor CBC and renal function, monitor for rash and superinfection. We want to avoid it during the third trimester of pregnancy, and they need to avoid antacids while they are taking this medication. Okay, so uh, trimethoprim, urinary tract anti-infective, Bactrim. I'm going to say it because I hate pronouncing this word. It has a synergistic effect. Both drugs together in one compound can cause bacterial resistance to develop much more slowly. Urinary, intestinal, and lower respiratory tract infections. It can treat otitis media, prostatitis, and gonorrhea. It's used to prevent pneumocystitis carni in patients with AIDS. Side effects and adverse reactions: moderate rashes, anorexia, nausea and vomiting, diarrhea, stomatitis, crystalluria, photosensitivity, agranulocytosis, aplastic anemia, and allergic myocarditis. And I'll tell you why patients probably have anorexia to this medication. It gives them a metallic taste, so they just really don't want to eat or drink anything. And that's saying something when you don't want to drink coffee and you're a big caffeine drinker and a coffee drinker. So that's probably a lot of reasons why that you're seeing some anorexic behaviors with this medication. It's just it's a nasty flavor that it gives you. All right, so topical uses of sulfonamides that can cause hypersensitivity reactions, so they try not to use it very frequently. Methionine acetate prevents sepsis in cases of second and third degree burns. Silvadene is used in the treatment of burns. Uh, Sulfocetamide sodium is ophthalmic and topical uses. Ophthalmic, used to treat conjunctivitis and corneal ulcers. Topically, it's used to treat seborrheic dermatitis and secondary bacterial skin infections. Dermatological form, of course, would not be used for the eye. So what about our nursing process? We want to assess patient's renal function. We want to look at a medical history with the patient. And it is contraindicated in patients. TMP, SMZ is contraindicated for patients with severe renal or liver disease. We need to make sure the patient doesn't have a hypersensitivity to the sulfonamide. Allergic reaction can include rash, skin eruptions, and itching. A severe hypersensitivity reaction includes erythema multiforme. So we need to make sure that we are given appropriate teaching for the patient and what they need to watch out for. We need to look at their current drug history. And we need to assess baseline lab results, especially a CBC. Our nursing diagnoses: risk for infection, ineffective protection, elimination. They could have impaired urinary elimination related to prolonged high doses of sulfonamide. Interventions: we want to administer sulfonamides with a full glass of water 1 hour before meals or 2 hours after meals. I started that on the previous slide. So administer with full glass of water 1 hour before meals or 2 hours after. Increase their fluid intake. Monitor for sore throat, bruising, bleeding. Monitor their CBC. Check for superinfection. Advise patient not to take with antacids. And tell the patient to avoid direct sunlight. All right, that's the end of your infection lecture. I was trying to keep it as short as possible. I will meet you in the discussion board later.